All right, so we've blasted through the patho, we've blasted through the signs and symptoms, the diagnostic workup, right? We'll go over another thing. So we've been kind of talking about all these things that we could do to determine the long-term treatment. But we're going to go over at the end, what would you do and how would you go about trying to determine if someone has a very life-threatening or near-fatal acute exacerbation of asthma. So we'll go over that at the end. But right now what we're going to do is we're going to try to determine what will we give to the patient based upon their symptoms. Okay, so let me explain what I'm going to do here. Some of you guys, if you're going in Clin Med, you'll notice that you'll probably see this chart a lot, and especially with asthma. We're going to go based off of this chart. So first thing we're going to do is we're going to classify the asthma based upon their symptoms. So we'll go type, frequency of daytime symptoms, frequency of nighttime symptoms that they're having this asthma, right? Their FEV1 between the exacerbations, and then we're going to talk about the medication protocol that will follow based upon this criteria here, okay? So the first one that we'll have is a patient presents with intermittent, okay? So every now and then, that's all that means. It's just intermittent, okay, type of asthma. So intermittent, okay? If they have this, we go based off, now here's the thing, some books are going to say 3, some books are going to say 2. When I learned it, mine was 2. So usually we'll say that they'll have less than, right, 2 symptoms. They'll have less than 2 times during an actual a week. So 2 times within a week, less than 2 times within a week that they've experienced daytime symptoms. For nighttime symptoms, we say that it's usually less than 3 times per month that they're experiencing nighttime symptoms. We then can do the PFTs and measure their FEV1 between the exacerbations, and that usually shows that they're actually greater than 80%. And then the medication protocol for someone who has intermittent every now and then type of exacerbations of asthma, we're going to give them a SABA, okay? So a SABA, again, we talked about this before with the diagnostic protocol, is a SABA is a short-acting beta-2 agonist. So let me just explain to you a little bit here, because I don't want to just tell you, oh, you give them a SABA. Some of you might not know exactly what a SABA is. So what we say a SABA is it's a short-acting beta-2 agonist. So and this usually there's a couple different types of drugs that you could give here. Classically it's the albuterol, and sometimes you can give a lower dose, and this is called levoalbuterol. All these drugs do is if you kind of want to know their mechanism of action, is imagine here I have a cross section of a bronchial, right? Here's the lumen, and then you have the smooth muscle, right? So here, we'll just kind of draw here, kind of like this, some smooth muscle. The smooth muscle has 2 different types of receptors on it. One has muscarinic receptors, and the other one is it actually has beta receptors. The particular type of receptor that you're going to see on these for this situation is going to be beta-2 adrenergic receptors, right? Now what happens is if you give a SABA, you give it in an inhaled form, right? And they usually give these in 2 forms. You can give them what's called an MDI or a meter dose inhaler, and they give it with like a spacer, and actually helps to push the actual chemical back into the throat and then has an increased density with the spacer to yank it down into the lung tissue. Or you can do a dry powder inhaler or DPI. Sometimes you can give them in nebulizers as well. But generally we give these, they work into the airway and they bind onto these beta-2 adrenergic receptors. What does epinephrine do or norepinephrine do when they bind onto the beta-2 adrenergic receptors in the respiratory airways? They dilate. So the mechanism of action here is it's going to produce bronchodilation. Okay? Now here's the thing. Sometimes when you're giving these beta-2 receptor agonists, they can actually sometimes they can affect other tissues. So what do I mean? Some of the things that you want to be careful with adverse drug reactions is it can actually affect the heart. So sometimes it can produce tachyarrhythmias. So it can produce tachyarrhythmia. It also can act on the skeletal muscle, and it can produce tremors. So sometimes it might even cause tremors. and it even can produce dizziness as well, affecting the cerebral blood flow. Never give, these are usually contraindicated in patients that have some type of underlying cardiac abnormality like a heart block. And also, don't want to give these to patients who have some type of narrow angle glaucoma, because whenever you do that, it can actually cause the lens to protrude even more forward because it affects the ciliaris muscle. And when it does that, it can actually kind of occlude that canal Schlemm or the sclerovenous sinus, which can lead to increased intraocular pressure. So again, that's the same thing with SABAs and another drug that we'll talk about called LABAs. But these are pretty good drugs. And again, this is the one that you would go to. Now, because it's intermittent, we're just going to do it PRN whenever they're experiencing those exacerbations. So we're going to put SABA, but particularly we're going to give it PRN, just as needed. Okay? So that's the first thing. The next thing is we'll go to the mild stage. So mild is they're actually having greater than 2 episodes per week. Greater than 2 episodes per week for daytime symptoms. And then for night is they're having at least 3 to 4 times per month that they're experiencing these nighttime symptoms. Their FEV1's still probably going to be greater than or equal to 80% though. Should still kind of be normal, right? The protocol for this one is we're going to stick to giving them a SABA PRN, okay? So we'll give them a SABA, and let's assume that this is the same patient. It's kind of easier to do this in a stepwise fashion, like if you think about a patient getting worse over the time. They started off with this, they progressed into this, right? We're going to give them a SABA, but the best treatment for asthma is corticosteroids usually. So what we'll do is we'll give them what's called an inhaled corticosteroid. But the corticosteroid that we usually give is low dose. So we're going to give I'm going to put here low dose, and I'm going to put ICS, inhaled corticosteroid. So low dose inhaled corticosteroids. Now, when we talk about these, let's give an idea here of what we mean with this situation. So corticosteroids, some of you guys might know that they can come in multiple different forms. You can give these PO, so you can give them orally. You can give them IV, right? You can give them in an inhaled form. You can even give them intranasal. But in this type of situation, we're talking about inhaled corticosteroids. We're giving it through an inhaler. And these are usually 3 types of drugs that we would generally give. One is called fluticasone. The other one is called budesonide. There's also mometasone. There's many of these different types of drugs. But again, these are usually the ones that we're going to give are in the inhaled form. So these are inhaled. And most of the time, they're actually DPI, dry inhalers. Now, corticosteroids, their mechanism of action, think about it. Steroids are good at being able to decrease inflammation. Their main mechanism of action is they actually work. So imagine here you have some white blood cells. Let's say here I put some white blood cells here. So here's a white blood cell. And we're just going to, no specific type here. We're just going to say here's a white blood cell. What this white blood cell might do is it might release cytokines. So here we're going to say these are cytokines. And these cytokines are going to go and activate other white blood cells to undergo migration, right? And undergo chemotaxis to wherever this inflammation is. If we give a steroid, what it does is, a steroid is going to inhibit the cytokine release. It's going to inhibit the activation. And remember, what else did we say? Not only would it inhibit cytokine release, activation, but also this white blood cell is going to go to the area where the inflammation is. So let's say that here is where the inflammation is. Let's put like this right here is where the inflammation is. Okay? It's also going to inhibit the migration and chemotaxis towards that inflammation site. So by doing that, this is really, really good at being able to reverse inflammation. So inhaled corticosteroids are usually a very, very crucial protocol whenever you're treating someone with asthma. So again, you do low dose inhaled corticosteroids here. Again, fluticasone, budesonide, mometasone. But again, realize that with these ones, especially with dry powder inhalers, there is one common adverse drug reaction that can develop. It's not all the time, but it can. And this is where they can actually develop candidiasis or oral thrush. So one big ADR, adverse drug reaction here, is called candidiasis. And this is just oral thrush. It's a fungal infection, all right? And it usually can appear in the tongue, white mucus patches that actually, if you kind of peel them off or try to scrape them off, it produces a beet red inflammation. Okay, so this is why you want to make sure that whenever you take an inhaled corticosteroid, you always actually swish your mouth out with water and spit it out, because if not, it can actually lead to this candidiasis. Okay? But any corticosteroid can have systemic side effects as well. So that's the one thing. Now, let's go to the next step. The next step is we start to experience moderate symptoms. Okay? So moderate is we're at the point now where we're experiencing at least 7 times per week. Okay? 7 times per week we experience this. The next thing is you're starting to experience this at least once or more per week. So at least once or more per week of the nighttime symptoms. So actually, 7 times per week for the daytime symptoms, 1 or more for the actual nighttime symptoms. Now the FEV1 might drop. We might see it go between 60 to 80% between the exacerbations. It might kind of go between that range. Now the medication protocol here is we say we have 2 options. We're going to stick with the SABA and we're going to give that PRN. Okay? But if the inhaled corticosteroid, the low dose, wasn't working, what should we do? Bump up the dose. So then we're going to do a medium dose. So a medium dose inhaled corticosteroid. Okay? Now, sometimes, you don't always do this one, but you can do another thing where you can actually give another option. Instead of giving a medium dose, you can do a low dose inhaled corticosteroid plus a LABA. What the heck is a LABA? LABA is going to be a long-acting beta-2 agonist. It's not for acute exacerbations, it's for being able to treat symptoms long-term, right? But you really wouldn't do this. Why? What would you rather take, 3 medications or 2 medications? So you're probably going to have more compliance by taking 2 medications as compared to 3. So what we'll do is we'll most likely go with a SABA and a medium dose inhaled corticosteroid before we would actually add on another drug like a LABA with a low dose inhaled corticosteroid. Oopsie. All right. So that's what we would do here. Now, I'm going to write down here a LABA. LABA, same mechanism of action, same adverse drug reactions that you have to be careful of. The LABAs have one thing that we have to worry about though. One other thing besides these tachyarrhythmias, tremors, and dizziness. So first off, what are some of the LABAs? One is called formoterol or salmeterol. These are some of the long-acting beta-2 agonists. Here's the one thing I want you to remember. So the black box warning. 1, never for acute exacerbations. Never give this for an acute situation. It can actually make it worse. That's the first thing. The second thing is never give without a inhaled corticosteroid. Even if it's a low dose, you never give a LABA unless you're giving it in conjugation with an inhaled corticosteroid. So these are 2 things that you really, really don't want to forget when talking about a LABA. Okay? So these are those guys. Okay? Sometimes you can actually give these in combinations too. There's a lot of drugs that you can give LABA and corticosteroid combinations. Okay, so that's the thing I want you to know about with LABA. Now the next thing is we go to severe. Now the severe can actually branch into 3 individual treatment protocols. Okay, so the first thing is we have severe. Severe means that you're experiencing these daytime symptoms every day throughout the day. So it's throughout the day. Every day throughout the day. Frequency of nighttime symptoms, every night throughout the night. This would be terrible. Throughout the night. And particularly, usually every night. And an FEV1 that would drop below the lowest stage here, which is usually less than 60% of the FEV1 between exacerbations. Now, what did we finish off with? We said that we started with a SABA and a medium dose inhaled corticosteroid, right? Or we wouldn't generally do this, but we could do a low dose inhaled corticosteroid and a LABA. All right, so now in here we're gonna have 3 subcategories. Okay, so we're gonna go through these in like level of severity. Okay, so first thing that we're gonna try to do based off of this is we're gonna go back and we're gonna give them a SABA. We're gonna follow this whole protocol. SABA, PRN. What else were we giving them? A medium dose inhaled corticosteroid, right? We said that we should prefer this one. Now, if we give the medium dose inhaled corticosteroid, we can add in, so we can do that plus a medium dose inhaled corticosteroid plus a LABA. Okay? So what we'll do is we'll give a SABA, PRN, we'll keep the dose at medium, and then we'll add in a LABA. Okay? Then the second step is, if this doesn't respond properly, then we can result to doing, again, a SABA, PRN. We'll up the dose of the inhaled corticosteroid. So then we'll do high dose inhaled corticosteroid, and we'll also continue to give a LABA. And we'll see if they respond to that. If they still don't respond to that, the next step is we'll do a SABA continuously, again, PRN. We'll do a high dose inhaled corticosteroids. We'll do a LABA, okay, salmeterol, formoterol, and we might even have to do oral corticosteroids. So PO, oral, corticosteroids. Now we got to mention what these are. Okay. Now, we mentioned that these were the inhaled form. There's also the PO form, okay? That's not the pissed off ones. This is the actual PO taken by mouth. So now we can give corticosteroids, but let's say that these are given PO. This is usually methylprednisolone. This one can be given IV though. Prednisolone, prednisone, and then prednisolone. Nice thing about prednisolone is this actually can be given in liquid form as well, but generally we're going to give corticosteroids. So again, these can be taken PO. And sometimes you can even give them IV. And we'll talk about when we would kind of result to that. Particularly IV methylprednisolone and oral prednisolone. Now, these can have a lot of adverse drug reactions. When you're taking oral corticosteroids, especially systemically, they can produce a lot of different things. They can cause hypertension, they can cause hyperglycemia, they can cause sodium retention, it can depress your immune system, it can cause destruction of the actual muscle, the bone, it can cause steroid psychosis. So there's a lot of different side effects that this can cause. So again, you don't want to use these for a very long time. These are mainly short term. Okay? And really, it's only given in a situation like an acute exacerbation, or again, if they're not properly responding, okay? We're not going to give this long term though, short term, because of the actual terrible side effects that it can produce. Okay, so now, here's the other thing that we have to realize. This isn't the only thing that we can give them. We can give them other drugs. There's always these other options. Now, what are some of the other options that we can give? In replacement of like a low dose inhaled corticosteroid, and even in situations like a medium dose inhaled corticosteroid or a LABA, we can also give other drugs. I'm going to mention 3 of them. One is they're called mast cell stabilizers. This is usually something like cromolyn sodium. Okay, these are good specifically in situations like patients who in exercise or cold-induced types of asthma, and they inhibit the release of histamines by the mast cells, and they also inhibit the activation of eosinophils. Okay, so these ones are also going to be given to patients, but again, this would be more in patients with as an alternative, like atopic patients. Again, atopic meaning that they have allergic rhinitis, atopic dermatitis associated with the asthma. All right, so the next drug that we could give is leukotriene. I'm going to put this as LTRA, leukotriene receptor antagonist. This is going to be like montelukast. They also call it Singulair, okay? It does what it says. It binds onto the receptors, the leukotriene receptors, and inhibits the action. It blocks the action of leukotrienes. So it's going to inhibit a lot of that vascular permeability, the bronchospasms, the mucus production. Here's the one thing with this one. There's research being performed on this because it's actually been related to like suicidal attempts. So there's some type of research being done on the adverse drug reactions of suicide. But again, it's a pretty good drug being able to treat patients with particularly atopic patients. So again, associated with allergic rhinitis, asthma, and atopic dermatitis. And again, you could also use another drug called theophylline, but they never usually use that. That's more for patients with COPD who need diaphragmatic arrest. So again, theophylline probably wouldn't be utilized. But again, another alternative that we could utilize, especially in these severe stages, these 3 severe stages, is we could resort to what's called omalizumab. Omalizumab is actually it's an it's so cool, anti-IgE antibody. So what does that mean? Omalizumab can bind onto the IgE antibodies, and specifically in patients with a severe allergic asthma. Remember what we said IgE antibodies do? They bind onto the mast cells. They stimulate the mast cells to undergo degranulation, produce massive amounts of histamines and leukotrienes. By inhibiting that, that's going to help with the actual bronchospasms, the vascular permeability, the inflammation, the mucus production. Problem with this one is it's crazy expensive. And you actually have to go to the doctor like every 2 to 4 weeks to get this. Okay? So again, this could be indicated in situations, particularly in these last 3 stages here of severe asthma, particularly in those patients who have a severe allergic asthma. Okay, so that's how we would do this based upon symptoms. We're going to do one last thing, and that's going to be covering how we would treat a very life-threatening or near-fatal asthma. Okay, the last thing that I want to talk about is basically a emergent or acute exacerbation of asthma. Now, we talked about ways that we would diagnose these patients and how we'd be able to pick up on their signs and symptoms and the medication protocol, all that stuff. That's great, but what if a patient comes in and they are really like in a very severe, dangerous form of acute exacerbative asthma? What do we do? How do we diagnose it? What do we treat them with? So we're going to go through this, okay? It's kind of step by step. So let's say that you have that patient again, right? It's coming in. They had some type of exacerbation of their asthma, whatever the reason might be. They took their SABA and they didn't readily improve. You might want to do some specific testing, maybe, to see if they are having some signs of maybe some changes in the obstruction of the airway. So what could be some things that we could do? Well, remember we said that we do a PFTs? Those are the gold standard. Those are. But in an acute emergent situation, we're not going to want to do a PFT for multiple reasons. So what we might have to resort to in a situation like that is what's called a peak expiratory flow rate. We call them a peak flow. So in an acute exacerbation, acute asthmatic exacerbation, we might not have the luxury of doing a PFT. So what we might do instead is a peak expiratory flow rate. This is called a peak flow. When we do the peak flow, we base this upon like their age, their gender, their height, and things of that nature. And we usually want their peak flow to be greater than 70% of particularly their age range. Again, we can do gender, we can do height, things of that nature. Okay? And that gives us a little bit of information on that. So let's say that a patient comes in, okay? First patient we said, we're having some signs of exacerbation. They took their SABA, they improved. You don't really need to do anything. You could do their peak expiratory flow rate, but it's probably going to be greater than 70%. So you don't really need to go anywhere from there. Sometimes, you know, if you want to, you can do an ABG, but it's not necessary. Okay? Sometimes these patients won't even come in. Second situation, a patient comes in because they had some acute exacerbation. They took their SABA, but it didn't readily improve, and that's why they're coming in to get help. when they come in, you do a peak expiratory flow rate. And let's say that they have that peak expiratory flow rate and it's a little lower. Maybe it's like in between, let's say 50 to 70%. Okay? So the first patient, so here's patient number 1. They come in, right? They actually have a SABA. They take their SABA, they improve, discharge them. Okay? Next thing, patient number 2. They have the SABA after they have their exacerbation, doesn't readily improve. You do a peak expiratory flow rate, and it shows, it's actually less than 70%. Let's say that it's in between, 50 to 70%. Let's go with that. So a PEFR from 50 to 70%. Okay, that's definitely not good. We might want to do an ABG. But when will we definitely want to do an ABG? We probably want to do an ABG on a patient who has some type of underlying chronic lung disease. Okay, so we might do an ABG. But think about it. In a patient who's having an acute exacerbation of asthma, what's going to be happening? They're going to be breathing pretty heavy. So they're going to have tachypnea. And they're going to be breathing off a lot of their CO2. So if you did do an ABG is an arterial blood gas. It gives us the pH. It gives us the partial pressure of oxygen. It gives us the partial pressure of CO2. It gives us the amount of bicarbonate. Here, I'll write that down. So an ABG would give us pH. It would give us PCO2. It would give us PO2. And it would give us the bicarbonate concentration. This helps us to determine if the patient is in respiratory acidosis, alkalosis, metabolic acidosis, or metabolic alkalosis. If we did this, one of the big things that you'd probably see is that their partial pressure of CO2 is probably going to be a little lower. That's probably one of the big things that you'll see here. Let's do this here in red to kind of highlight that. So this is kind of the big thing that you might see here. Reason why is because they're breathing off a lot of their CO2. They're probably hyperventilating, okay? So that's one thing it might show. From there, we can go in and maybe determine if we need to give like a nebulizer treatment of a SABA and a SAMA. We'll talk about what I mean by that. All right, so then we have patient number 3. So for patient number 3, let's assume that the patient has been experiencing some acute asthmatic exacerbations, right? They come in, they come to the emergency room. When they come to the emergency room, they show some signs, like maybe you get their vitals, right? So you start them, you triage them, and you get their respiratory rate. And you find out that their respiratory rate is super high. Maybe it's like greater than 20 to 25 breaths per minute. You get their heart rate, and they're tachycardic. All right, so they have a heart rate that's greater than 100 to 110 beats per minute. You do a peak expiratory flow rate, all right? So you do the peak expiratory flow rate, and let's say that this sucker is between 25 to 50%. So you get a peak expiratory flow rate and it's between 25 to 50%. That is bad, okay? This is usually we're at the point of severe asthma, okay? So we find out that they have an elevated respiratory rate, an elevated heart rate, and let's just say that they actually are having a hard time being able to talk. They're having a hard time being able to complete sentences because they are having such a hard time breathing. In this situation, you definitely want to get an ABG. But the ABG is probably going to show you the same thing that patient number 2 had, which was a low CO2. The reason why is, look at what they're doing. They're going to be hyperventilating. Their respiratory rate's going to be up. So they're going to be breathing off a lot of CO2. Okay? Now, for patient number 4, let's say that this patient comes in. Okay, you find out, you do their O2 sats, okay? So you do the pulse ox. The pulse ox shows that the O2 sats are less than 92%, let's say. Less than 92%. That's no good. You find out that they are having a peak expiratory flow rate that's less than 25%. So they have a peak expiratory flow rate that's less than 25%. Oh my gosh, that's bad. You find out that they're actually not hyperventilating, okay? Another thing, here's what's really bad. This is when you know it's bad. There's no wheezing. Usually in someone who has an acute exacerbation of asthma, one of the big signs is wheezing upon expiration. You'll do the auscultation and you'll be able to hear it. Sometimes you can even hear it just by listening to them. But they'll have no wheezing. Another thing is, let's say that you do an ABG. And the ABG shows normal PCO2. That is bad. The reason why this is bad is if you see a normal PCO2, what were they doing before? They were hyperventilating. Now, at this point in time, there's no wheezing. You don't hear any wheezing. Their peak expiratory flow rate is less than 25%. They can't even really talk. Their O2 sats are super low. And let's say that they're not even hyperventilating anymore. Their respiratory rate is actually normal or very low. Guess what's happening? The airway is becoming so obstructed that the CO2 isn't even being able to be exhaled. Before, the PCO2 was low, but the airway is becoming so obstructed that the PCO2 is starting to build up, build up, build up. And it's going from low PCO2 to normal PCO2. This is the bad sign. This means they're going to turn the table and they're probably going to start going into a near fatal exacerbation. So once you see a normal PCO2, no expiratory wheezing, a peak expiratory flow rate less than 25%, O2 sats that are pretty low, less than 92%, this means that they are probably having a complete airway obstruction. And at this point in time, this is when they usually turn the corner, and they actually, not in a good way though, they usually start going into a near fatal exacerbation. So this is where we would lead to the last patient, patient number 5. We do this one, and we see that the patient, we do an ABG, okay? Let's say that they're showing very similar signs, very low O2 sats. So super low O2 sats, okay? Very low, less than 92%, let's say. Again, peak expiratory flow rate is actually less than 25%. Okay, peak expiratory flow rate less than 25%. No wheezing. Okay, they can't even talk. You do an ABG, and the ABG shows that you have an elevated PCO2, partial pressure CO2, in the blood. This means that we are completely at the point of obstruction, and now the CO2 levels are starting to build up, and we're starting developing respiratory acidosis. Now, in this situation, this is where it's really bad, okay? You need to treat the patient immediately. Sometimes you don't even have time to do an ABG or to do a chest x-ray to see if there is some type of underlying pneumonia. You might have to treat them immediately with supplemental oxygen. So what should be the treatment protocol here? The treatment protocol here is you should resort to first step. So we're going to go through the first step. First step is get them on a non-rebreather. This is way better. Non-rebreather, supplemental O2 with a SAT. You want it to be greater than 92%. You want that actual level set greater than 92%. So we're going to put them on a non-rebreather. That helps to push a lot of oxygen in them as compared to like a Venturi or like a nasal cannula. So we're going to want to do that. The second thing that we're going to want to do is we're going to want to put them on some short-acting drugs. So we're going to give them SABA, okay, which is a short-acting beta agonist. This is going to be albuterol. But what's best is to give it with another drug. We didn't talk about this one, but it's called ipratropium bromide. Okay, so ipratropium bromide. We usually are going to give these two together, and we can give it in two ways. We can give it in a nebulizer treatment, so we can give it in either through a nebulizer or through like an inhaler. Okay? Ipratropium bromide, just a basic thing, is an anticholinergic. All it does is it binds onto the muscarinic receptors and prevents acetylcholine from binding. What does acetylcholine do if it binds onto the muscarinic receptors in the respiratory smooth muscle? It causes bronchoconstriction. Ipratropium bromide is going to block the acetylcholine and allow for the actual smooth muscle to relax. So that's why we would give these two drugs. This is a short-acting muscarinic antagonist. Now, let's say that we did the non-rebreather with the supplemental oxygen set greater than 92%. We give them a short-acting beta-2 agonist like albuterol and ipratropium bromide. If that doesn't work, remember what we said we can resort to in very severe situations? Steroids. So then we can give IV or PO corticosteroids. Okay? And we'll do this for a very short period of time to see if we can reverse the inflammation. Now, what if that doesn't work? The next thing we have to do is we're going to do what's called IV magnesium sulfate. This is in very severe situations, because what magnesium sulfate does is it actually blocks the calcium channels in the smooth muscle. What happens if you block calcium channels? Calcium is needed for the smooth muscle contraction. So it's going to inhibit it, and it's going to promote very intense smooth muscle dilation. If this doesn't work, the fifth step is that we'll put them on positive pressure ventilation, like a CPAP, right? And if that doesn't work, we might have to intubate the patient, okay? And this would be through endotracheal. Okay, so these are kind of the steps that we would go through in this kind of acute exacerbation. So again, if someone comes in this stage, what we would first do is supplemental oxygen, non-rebreather, get a lot of oxygen into them, greater than 92%. SATs, right? Then we would do short-acting beta-2 agonist, like albuterol, and ipratropium bromide, which is a short-acting muscarinic antagonist. These in combination via nebulizer or inhaler is going to really help to dilate those airways. If that doesn't work, we can then resort to IV methylprednisolone or PO prednisolone to be able to reverse the inflammation. Then, if that doesn't work, we can go to IV magnesium sulfate. This is going to help to be able to promote intense smooth muscle dilation. If that doesn't work, we might have to send them to the ICU where they'll have to do positive pressure ventilation, right? And then if that doesn't work, we might have to intubate them. But eventually, whenever we discharge the patient, we usually send them home with an oral corticosteroid taper for a couple days, like a Medrol dose pack. Okay, so that's how we would go about being able to treat a patient with an acute exacerbative asthma. All right, engineers, so in this video, we covered the treatment protocol for asthma. We went over it in great detail. I know it was a lot. I hope it made sense. I hope you guys enjoyed it. If you guys did, please hit that like button, comment down in the comment section, and please subscribe. Also, if you guys could, go down into our description box. We'll have links to our Facebook, our Instagram, our Patreon, and even our GoFundMe page. If you guys could donate, we would truly appreciate that. All right, engineers, as always, until next time.